I'd like to introduce a speaker. The title, as you know, is The Trouble with Malaria in Africa. And Professor James Webb is a pioneer in the field of historical epidemiology. His work integrates approaches from the biological sciences and the social sciences to produce perspectives that are useful to historians, practitioners, and planners in the field of global public health. He is the founding editor of two book series at Ohio University Press, Perspectives on Global Health, and the series in Ecology and History. He is currently writing a book on the history of malarial infections and interventions in tropical Africa. So please help me in welcoming Professor Webb.
Well, my thanks to Anouar and the Center for Global Humanities for the invitation to speak tonight. It's an honor to be here and a pleasure, too. My wife has just completed her MPH degree at UNE, and I feel a sense of vicarious pride in her achievement and gratitude toward the School of Public Health, mixed with relief that we have no more tuition payments. So, African malaria is very much in the news these days, and many of you are aware of the efforts to distribute insecticide-treated bed nets to African households, to spray residual synthetic insecticides indoors, to diagnose malarial infections rapidly, and to get therapeutic drugs to people who fall ill. The contemporary campaign to control malaria in tropical Africa has produced impressive results. It's substantially reduced deaths and severe illnesses. The malarial burden, however, is still very high, although no one can be sure of the numbers. Perhaps 600 or 700,000 children die every year, and hundreds of millions who have survived the childhood challenges suffer non-lethal malarial infections. So I'll just refer to the slide here, and I've been informed I should describe it just briefly because this is being taped and is going out over the radio. So here we have a photograph of an Anopheles mosquito, which is the it is the only vector for malaria. And the Anopheles mosquitoes, in case you find one in your house, and we have Anopheles mosquitoes in Maine, if you find one in your house and you see them biting, you will be able to identify them because they have their rear end up in the air when they bite, and that's kind of the distinctive posture of the Anopheles mosquito. This is a map, spatial distribution of Plasmodium falciparum stratified by endemicity class. And this map suggests some of the biophysical parameters of transmission. Most malarial infections in Africa are caused by this Plasmodium falciparum parasite. It's just one of 4 major parasites that cause this disease that we call malaria. And it's the most dangerous of the parasites. And in sub-Saharan Africa, the malarial infections are principally caused by falciparum. It's probably responsible for about 90 or 95% of all of the malarial infections. So this is one reason why malaria in Africa is just really serious. The most globally, widely distributed parasite in the world is not falciparum, it's vivax malaria, which is far less severe as an infection. But in sub-Saharan Africa, it's pretty close to 100% falciparum infections. That's one reason why African malaria is kind of a tough problem. Another is that the African mosquitoes, the vectors that carry that transport the parasite, are among the most efficient in the world, which is to say that they accommodate the parasite very well. They don't really get sick when they get infected by the parasite. They tolerate it very well. It goes through its life cycle within the mosquito. And the African mosquitoes are pretty long-lived as well. So this is another reason why transmission is pretty high. Well, in the midst of the contemporary successes, as I've mentioned, significant decreases in the number of deaths, mortality, and the amount of severe illness, there have been some disturbing trends. The number of insecticide-treated bed nets distributed this past year in 2012 is less than 1/2 of the number that were distributed in 2010. The use of insecticides has selected for mosquito resistance, and insecticides in some settings have become less effective in killing mosquitoes. The use of anti-malarial drugs has selected for resistance, and some drugs have become less effective in killing parasites. And donor interest in malaria control is waning. Comparable experiences are documented in the records of the first malaria eradication campaign of the 1950s and 1960s. And the trouble with malaria that I'm going to talk about this evening is that we've been making malaria policy decisions without knowing much about the long and troubled history of malaria control in tropical Africa. Several years ago, when I was writing Humanities' Burden, A Global History of Malaria, I began to investigate the scientific literature on malaria in tropical Africa. I'd assumed that there would be a pretty substantial literature that would allow me to understand the major interventions of the 20th century. To my surprise, there was not. There appeared to be little of an historical nature to investigate. The scientific literature was agreed that tropical Africa had not participated in the World Health Organization's Global Malaria Eradication campaign that ran from 1955 to 1969. On the off chance that there might be more to the African malaria story than had appeared in print, I wrote a letter to the incoming archivist of the World Health Organization. The timing was propitious. The institution had just decided to open its parasitological archives, and I was the first researcher admitted to them. During a preliminary research trip to Geneva, I began to discover elements of an extensive history of malaria control and attempted eradication in tropical Africa that was largely unknown to contemporary malaria specialists. And this slide I'm showing here is the frontispiece of the Afro-Malaria Eradication Yearbook, number 1, 1959, which I discovered completely by accident in about the 3rd month of working through hundreds of boxes of malariological materials in the parasitological archives. There were hundreds of boxes of reports. Initially, I concentrated on gathering data about past interventions in mosquito control, the destruction of mosquito breeding grounds, the killing of mosquito larvae and of adult mosquitoes through the application of natural and synthetic insecticides, and the physical blocking of malaria transmission through bed nets and repellents. I also gathered evidence about past interventions in chemical therapy, both for prophylaxis, to prevent infection, and for cure. And at a later point, I realized that it would be desirable to integrate these lines of investigation in order to understand the impact of interventions on infections. For example, insecticides could and did change the species composition of the mosquito fauna, eliminating some species and opening up ecological niches for others with different vectorial capacities. Some chemical therapies operated differentially on the malaria parasites. and thus changed the mix of malarial infections. At length, I began to realize that African malaria was a dynamic epidemiological and historical problem rather than a constant feature of African life. And I also began to understand more clearly some of the unintended consequences of malaria control. So here is a thumbnail sketch of malaria control in the period of the 1940s, 1950s, and 1960s. In the aftermath of the Second World War, while most of Africa was still under colonial rule, British Empire, French Empire, Portuguese Empire, Belgian Empire, the United States of America pioneered the large-scale use of synthetic insecticides. DDT, to be sure, but also more dangerous chemicals, including dieldrin and benzene hexachloride, and new inexpensive synthetic drugs such as pyrimethamine and chloroquine. DDT in particular promised an inexpensive method of mosquito control, and DDT was considered to be just fabulous. It raised the prospect of effective public health interventions without having to create public health systems. You could just go in and spray. You could solve a major public health problem. You didn't have to set up a public health system. This seemed at the time to be the very essence of public health economy. Enthusiasms ran high. Early programs demonstrated that in urban areas, the new malaria control tools could drive down the number of malarial infections to very low levels. If you went into urban areas and you sprayed DDT, and if DDT didn't work, because in some of the areas in West Africa, the houses were made out of lateritic soils that were sorptive and drew in the DDT, so it didn't have a residual killing action. The interventionists went to other synthetic insecticides, particularly dieldrin and BHC. It was fabulous. You could drop the level of infections by 90%, by 96%, by 98%, by 99%. You just couldn't get to zero. The initial successes in urban areas raised the question, would it be possible to control malaria in rural Africa? In 1950, the first conference on African malaria was held in Kampala, Uganda, where this was the major policy issue. Should the World Health Organization embark upon indoor residual spraying with synthetic insecticides in rural African regions of intense malaria transmission? Africans in these zones who had survived childhood infections had acquired a partial immunity to malaria, and as a result, suffered less severe bouts. The real problem in the 1950s, as today, was among children under the age of 5, when their immune systems were immature and the burden of severe disease and death was concentrated in the under 5 group. If you survived those initial challenges, you could still get sick, but the sicknesses were not very severe. Many people were heavily parasitized. In many areas of tropical Africa, you had what was known as the effective inoculation rate, the number of times you were bit annually by an infected mosquito. And it could be 80 times a year, or 100 times a year, or 800 times a year, or 1,000 times a year. You could receive an infective bite 3 times a day. You could be very heavily parasitized and completely asymptomatic, because your immune system if robust, was able to handle the parasitemia. But the maintenance of this acquired immunity depended upon recurrent inoculations. You had to continually be challenged by infective bites in order to maintain a robust immunological status. So one concern was, well, if efforts to control malaria in rural Africa were launched, and if the interventions were successful, they might compromise Africans' acquired malarial immunities, about which little was known. And if the control efforts were subsequently to fail, the populations that had been protected by the spraying campaigns might lose their immunities and suffer rebound epidemic malaria with severe consequences. So at the heart of this very fractious dispute in Kampala in 1950, at the first conference on African malaria, there were two issues. One was, well, if you believed or if you disbelieved in the possibility of the eradication of malaria. I mean, after all, if you believed that it were possible to eradicate malaria, then the issue of rebound epidemic malaria was moot. It didn't matter. There were many such believers. The second issue was the extent of childhood mortality owing to malarial infections. I mean, how serious was the problem of childhood death and disability? It was surprisingly only in the 1950s that the medical community moved closer to a consensus on the issue of childhood mortality. Childhood morbidity and mortality were conceptualized as costs that were paid to acquire adult and adolescent immunities. If the costs, the medical costs, were high, well, then there was more of an argument for intervention. If, in fact, Africans, young Africans under the age of 5 didn't suffer greatly and managed to acquire immunity, then there wasn't much of an argument for intervention. So in the aftermath of Kampala in the early 1950s, the medical community came to accept an estimate of 25% of childhood mortality, childhood deaths, that were directly attributable to malaria. And thus, for those who accepted this estimate, the second of the reasons for caution in malaria intervention dissipated. By virtue of the good that could be conveyed to those in the early years of life through the prevention of malaria transmission, the concern over any potential vulnerability that might be incurred by adults in areas of heavy transmission where the acquired immunities have been compromised through malarial interventions faded away as an issue. This is a slide of the siting of the pilot malaria eradication projects in 1960. Many were supported directly by the World Health Organization. Others were benefiting from assistance from the World Health Organization. Some of you will know that malaria was considered to be the largest global burden of disease at the end of the Second World War. The World Health Organization, at its formation, took up the banner of the League of Nations, which had preceded its health organization in its malaria division. The disease of malaria was the first candidate that was identified for possible elimination, eradication globally, and the first effort to try and eradicate one of the major human diseases was that of malaria, and the campaign built up in the course of the late 1940s and 1950s, and the World Health Organization announced in 1955 that it would go for global eradication of the disease. It was the largest public health program in history. The World Health Organization launched pilot projects in a lot of different ecological zones. They launched them in forest areas, in savanna areas, Sahelian areas, coastal areas, highland zones. It was understood that there was so much variation in transmission in sub-Saharan Africa that any protocols for eradication would have to be worked out on an ecological basis, and that what was going to work in the Sahel was not going to work in a coastal area and was not going to work in a forest area. This is the first of two slides that I'll show from the Liberian campaigns. The Liberian campaigns were the first of the WHO pilot projects. They were the ones that had built upon the interventions of the Americans, who began spraying indoor residual insecticides in 1945. By the mid-1950s, evidence was accumulating that indoor residual spraying, also known as IRS, but not to be confused with the Internal Revenue Service. Evidence was accumulating that indoor residual spraying, or IRS, alone would not be able to interrupt the transmission of malaria. I mean, IRS worked really great. You could kill most mosquitoes. But when you placed heavy selection pressure on the Anopheles mosquitoes, you selected for mosquitoes and for a gene that was resistant to the insecticide. At a World Health Organization technical meeting in 1957, the malaria experts unanimously recommended the initiation of large-scale experiments with the mass administration of anti-malarial drugs. The recommendation, like that with residual spraying, was to try things out, to employ different drugs and different dosage schedules to determine the efficacy of the interventions. This is another slide from Liberia that just shows the administration of anti-malarials. And down here in front, you see a little WHO newspaper, which is part of the propaganda campaign for the Global Malaria Eradication campaign. The availability of inexpensive synthetic drugs breathed a second life into the pilot malaria eradication projects. If the insecticides alone couldn't completely interrupt transmission, perhaps the drugs might be able to clean up the human reservoir of parasites. Perhaps with the combination of insecticides and drugs, it would be possible to reach the goal of zero transmission. Alas, researchers discovered that anti-malarial drugs in combination with synthetic insecticides could drive the rates of infection extremely low. They could drive them below a 1% transmission level that had previously obtained. But they couldn't get to the point of fully interrupting transmission. And this was a problem because the cost of spraying is about the same every year. And all of the benefits from the spraying came in the first few years of the project. You moved infections down by 50%, by 80%, by 90%, by 95%, by 98%, and then it stayed at that level. And you still had high recurrent costs every year without much change in the level of transmission. When it became undeniable that eradication could not be achieved with the tools at hand, the malaria eradication projects were closed down. Rebound epidemic malaria beset the communities that had been protected by indoor residual spraying and chemical prophylaxis. The most successful projects, those in which transmission had been driven to negligible levels, bequeathed the greatest suffering. because the protected populations experienced the more complete degradation of their acquired immunities. The medical consequences of rebound malaria went unexamined. The ethical dimensions of shuttering the malaria eradication projects went unexplored. The World Health pilot eradication projects, of course, were not the only ones that were beset by epidemic malaria. In the French colony of Madagascar, a malaria control program was initially highly successful. As early as 1949, the French had launched a program to enroll the school-age children in the highlands in a malarial prophylaxis program using quinine. In the 1950s, chloroquine replaced quinine, and in combination with indoor residual spraying with synthetic insecticides, the program achieved good success. But it did not fully interrupt malaria transmission. The number of infections, however, dropped to a very small number. By 1957, malaria transmission had been reduced to such a low level that it was no longer a significant public health problem. Thereafter, and quite understandably, control efforts slackened and were cut back progressively in the early 1960s. After all, there was little malarial disease to prevent. And then in 1975, there was a significant uptick in infections. At first, the outbreaks remained localized. They blossomed slowly among a population that had grown up immunologically naive, without acquired immunities. In 1977, in Antananarivo province, there were 37,000 clinical cases and 140 deaths, and thereafter the epidemic spiraled upward, reaching 1,600 deaths in 1984, doubling to more than 3,000 deaths in 1985, doubling again to 6,500 deaths in 1986, reaching a peak just under 10,000 deaths in 1988. When the data from an adjoining province was added, researchers estimated the death tolls at about 15,000 per year during the 4 worst years of the epidemic. The cause of the epidemic was undoubtedly complex, but beneath the swirl of countervailing forces was the fundamental epidemiological fact that the malaria control program had created a population nakedly vulnerable to malaria. By the mid-1970s, when the increase in infections started, the people living in the highlands of Madagascar were non-immunes. By the late 1980s, when the epidemic had been brought under control, the grave sites of the tens of thousands of victims marked the public health tragedy of malaria control and lapse. The creation of non-immune populations is one of the unavoidable and integral consequences of successful malaria control. It wasn't one that was restricted to highland areas. From 1980 to 1981, a malaria eradication project took place on the islands of Sao Tome and Principe in the Gulf of Guinea. As had been the case on other small islands, local transmission could be fully interrupted by using synthetic insecticides. When you have a really small area, some of the best successes in full eradication take place on islands because you can actually spray everywhere. The interventionists believed that eradication was at hand. In 1983, however, migrant fishermen reintroduced falciparum malaria to the islands inadvertently, and in 1986 an epidemic broke out. It took more lives during its 10-month reign than had died from malaria in the 7 years before eradication. When malaria programs have lapsed after a number of years of successful control, Rebound epidemic malaria has afflicted formerly protected communities, and the health consequences of the epidemics have gone largely unmeasured. In part, this may be because of the metaphor of rebound, which suggests that the disease has bounced back to its pre-intervention levels. I mean, if the loss of control results in the reestablishment of a pre-existing equilibrium, African communities might be no worse off than they would have been otherwise. Yet the evidence from as early as the 1940s indicates that lapsed malaria control has resulted in the loss of acquired immunities and new vulnerabilities. Because when malaria transmission is reestablished, even if at far lower levels than previously, the burden of disease is shifted to members of older age cohorts who had previously enjoyed greater protection by virtue of their acquired immunities. For older individuals and those who suffer from HIV or other infections that compromise the immune response, the reestablishment of malaria transmission will cause an increase in serious illness and in death. The logic of the expansion of highly effective, yet potentially unsustainable public health measures has held the day because malaria control has been represented as an unimpeachable good. Yet when the phenomenon of resurgent malaria is acknowledged to be a possible outcome of lapsed control, and there's no ironclad commitment to funding ongoing malaria control projects, the moral dimensions of malaria interventions are no longer simple and straightforward. It's indisputably noble to save the life of a child. The moral calculus becomes more complex if rebound malaria takes out the life of the grandmother. The long history of malaria control in tropical Africa is of control and lapse. In the past, when commitments to malaria control have waned, the interventionists have enjoyed a kind of immunity from moral censure. After all, there's no opprobrium attached to doing one's best and failing. The ethical issues went unexplored. But with a fuller understanding of the historical record of control and lapse in tropical Africa, and of the vulnerabilities of communities who've been temporarily protected by malaria control and then have lost their protective acquired immunities, the contemporary malaria control community of donors and practitioners has an ethical obligation to uphold fully its responsibility to safeguard the health of Africans under its care and to plan for the eventualities of lapsed control. Okay, so I'm going to just now offer a few brief reflections on the kind of the role of history in this field, which for many people doesn't quite seem like history at all. I mean, we often think of history as political history or social history or cultural history, but this is a history of infections and a history of interventions, and so it's a field that is known as historical epidemiology. So let me just say a few words about that. I think that the major contributions of this field of historical epidemiology are to provide greater definition to the spatial and temporal extent of past infections through the use of historical records. So this isn't kind kind of historical antiquarianism, where we're interested in old records for the sake of old records. We're interested in old records because they're directly germane to contemporary interventions. Historical epidemiology can help also us to consider social, political, and economic variables that are generally outside the purview of epidemiological studies. And historical epidemiology can help us to investigate how past control efforts and medical interventions have changed the nature and the dynamics of disease transmission. So we need to get away from the idea that some of the diseases that we're trying to control or to eliminate don't have histories. We need to get away from the idea that, well, there's always been malaria in Africa, and there's still malaria in Africa, and now we're fighting malaria in Africa. No, in fact, the interventions themselves are shaping the nature and the dynamics of disease transmission. So historical epidemiology, the study of the changing patterns of disease over space and time, is just emerging as a field of scientific inquiry. Researchers in parasitology, entomology, immunology, and biomedicine rarely have cross-disciplinary training in these sciences, and in my experience, never have training in historical research methods. And conversely, historians rarely have training in any of the applied sciences. I believe that a partial solution to this conundrum is to integrate historical epidemiology into schools of public health, either in departments of global health or perhaps into departments of epidemiology. The goal, put straightforwardly, is to put historical research at the service of public health. There are immensely practical reasons for doing so. Today, for example, we are using many of the same tools to control malaria in the same areas to control malaria that were deployed in the past. And thus, the record of past interventions is directly relevant to contemporary interventions. Some of the findings of this project on the historical epidemiology of African malaria are cautionary. The findings are of the severe consequences of epidemic malaria that erupt when full control successes lapse. From this point of view, the failure of malaria control specialists to understand the historical epidemiology of African malaria constitutes a significant public health risk to the African populations that they wish to protect. And this is my final slide, which I will just read because some people are listening to this on the radio. And it says, a National Institutes of Health grant award for scholarly writing in biomedicine and health helped to fund this project on the historical epidemiology of African malaria infections and interventions. So that completes my presentation here for this evening, and I would be delighted to take questions from you.
Thank you very much. That was excellent. When you have the combination of the fact that immunity provides at least partial protection, particularly against mortality, and the fact that a non-immune adult population is greatly at risk, this just cries out for the obvious answer, which is a vaccine. And yet attempts at this have been largely unsuccessful. Would you comment on that? Yes, I will comment on it.
Our experience with making vaccines has been very good against viruses and very good against bacteria, and it's been very poor against parasitic diseases. This, I think, is largely owing to the fact that the life cycle of the parasites is extremely complex, and all of the Vaccines have to be stage-specific and target one aspect of that life cycle. I think that there's another issue here, which is that vaccine makers have in the past received funding and support from government agencies and from the military. They have a very specific goal, which is that they want to prevent the transmission of malaria, 100% protective. We want to be able to put troops in tropical Africa or other malarial areas and make sure that they're not going to get malaria. This is a perspective of the non-immune. It's a perspective of kind of non-tropical African populations. It was a perspective of the colonial regimes. It can even be thought of in an historical sense as a white perspective on malaria. The vaccines that are being developed, most are aiming for the goal of 100% success. I think from the point of view of African populations that are likely going to continue to receive multiple inoculations with malarial parasites over the course of any year in their life, that the goal of the vaccine would not need to be 100% effective. One could work toward a far less effective vaccine, but this will not serve the needs of the non-immune. And right now, we're still working from the perspective of the non-immune. I was talking to somebody at the WHO a couple of days ago, a fellow who's head of vector control. And I asked him just to speculate on where he thought things were going, 20 years from now or 50 years from now. And he said he really wouldn't go there, but he was sure that 50 years out, we'd still be 5 years from the vaccine.
Great talk. I spent some time in Africa, and it seems like from the late 50s until the late 80s is that chloroquine phosphate and nevaquine was used, and almost it was, it caused a lot of complacency, I thought, because you go to someone's house and they would have a can of nevaquine on the dining room table. And I worked in a project called Child Survival, and one of our strategies was to treat fevers, to knock down the parasitemia. And I remember very distinctly, we had a meeting, this guy, he was the head of malaria, a guy named Dr. Beausoleil, a Haitian. He said, we've got chloroquine resistance in Kenya. And he said, not to worry, it won't be in West Africa for 5 to 10 years. And it was in West Africa in 18 months. And so chloroquine went from being the silver bullet to maybe to knock down some parasitemia. I don't even know if it's used anymore. And subsequently is that they've played around since maybe the 20 years or so since nevaquine is no longer. There are all sorts of regimens that are being used, and they seem to become obsolete within a couple of years. And so my question, is there any evidence that people just thought they were very comfortable with chloroquine and research didn't go forward? That was my impression, because say, treat the fever and give them a few aspirin, they'll be okay. And one historical note is that I worked in smallpox eradication, and a lot of the malaria eradication people did go on to form the backbone of the field staff of smallpox in both Africa and the subcontinent. So they didn't go down, wasn't wasted.
Right.
Thank you.
Right. Sure. Well, just let me say a few words about chloroquine. Chloroquine was a miracle drug, and it worked for a really long time, and it was very inexpensive. I mean, it was so inexpensive that it was within the means, really, of the poorest of the poor. I mean, it was a penny or two a dose, and you could buy chloroquine in small shops throughout Africa. It's one of the ironies of malaria control that probably the most successful chapter in the history of malaria control is one that did not involve intervention by international donors. which is to say during the 1960s and 1970s, African governments and African merchants imported large quantities of chloroquine and distributed it because they could make money at it. And it worked to reduce childhood mortality, and it reduced adult morbidity. And it was highly successful. And it was so successful that certainly one of the principal forces that broadened the demographic, the age pyramid, and produced a decline in per capita incomes in Africa during the 1970s and 1980s, because you had many more child survivals per adult. However, the drug, which was really had quite a long run, was very extensively used and worked well for decades, began to produce resistance in Africa in the late 1970s and then spread, so that there were no other dramatic breakthroughs and chemical therapies until relatively recently. So we went through a period from the mid-1980s or so into the late 1990s when the drugs that could be used for curative therapies were much more expensive. And those ones that were used produced resistance relatively quickly. So now it is the case that the gene that in the parasite that works to prevent the efficacy of chloroquine apparently is not very robust, and it doesn't have a high survival purpose, so that in areas where chloroquine has ceased to be used at all, as in Malawi, where this has been studied pretty well, we may be entering a new era of chloroquine efficacy. It may be that we have to use twice as much chloroquine as we used before, but it's possible that chloroquine may have a second life. Here again, though, when we think about chemical therapies, it's useful to use this idea of the non-immune perspective and the partially immune perspective, because from the point of view of the non-immune who gets malaria, traveler from the United States of America goes to Malawi and gets sick, what that person wants to do is take a curative dose, clear the infection. If you are living in Malawi and getting 130 or 180 infective bites a year, there's not a lot of sense in clearing an infection because you're going to get one tomorrow. What you're concerned about is preventing the severe symptoms that you could get with a high level of parasitemia, and you want to prevent death. And in that way, there are many drugs which are not fully effective, but which are partially effective, and which can be used for some therapeutic purposes. And in fact, this may be the best way to understand the entire world of African pharmacopoeia, where people use plant-based medicines of various sorts. They aren't effective at all from the point of view of the non-immune. You cannot clear an infection with them. You can, however, with many of these plant-based medicines, reduce the levels of parasitemia and reduce the number of complications that you're getting from severe malaria. So, for example, one of the mainline drugs, Fansidar, sulfadoxine, pyrimethamine, that was used in the 90s and into the early years of this century, is now still being used for certain types of interventions that are not aimed at clearing infections. So we're using this drug known as, shorthand as SP. SP is used for treating pregnant women who have malaria in order to reduce the level of parasitemia, not to clear the infection. I believe it's also being used for the same purpose, intermittent preventive therapy for infants. So that the utility of some of these drugs, which seem outdated and resistance has emerged, so we can't use them. We can't use them for non-immunes. But that doesn't mean they don't have a different purpose that can be used that's not curative, but which is ameliorative to improve health outcomes for people who are partially immune.
Okay. I find it really interesting, the line you seem to be drawing between the non-immunes and I guess you would say those infected. And I was just wondering, what kind of agency do those infected have when they're over there making decisions for themselves, or are these more strategies for eradicating malaria that are imposed upon them?
That's a really good question. I think that having policies imposed on them is probably a little bit harsh. I think that certainly African communities and some medical personnel are concerned about this issue of rebound malaria, particularly in areas in which the pilot projects took place, and there is a memory of this. This is true in Senegal, and it's true in other areas like Zanzibar. We're around the third eradication campaign in Zanzibar right now. Tried it twice before and it didn't work out. But I think it's a question that we'll know more about probably in a few years, because we're coming up against the prospect of and the reality of reduced commitment to control, so that the environment for thinking about malaria control strategies as opposed to elimination is changing pretty rapidly.
Couple questions. This has been fabulous. Thank you so much. It's been very interesting. And I just wanted to remind especially some of the students that one of the very few, if maybe one of the only major federal agencies that's not within an hour of Washington, D.C. in terms of their headquarters is, of course, the U.S. CDC, which is in Atlanta, Georgia, because its main mission when it was born out of World War II was to eliminate malaria in the South East. So just a little bit of a trivia. We have our own malaria history in the United States. And a couple questions. One is about the Bill Gates Foundation and what Bill and Melinda Gates Foundation and what their strategies are. And the second thing is I think my recall on this is more anecdotal than in my own experience in Africa than maybe studies, but I can't remember, which is that I believe there's some evidence that children who do die of malaria tend to be not only from more impoverished families, but along with that have exposure to a lot of other infections such as waterborne diseases, poor nutrition, and the like, and that there's some evidence that if some of those are addressed, that they have a good, clean, safe source of drinking water, and that they're vaccinated against diseases that you can be vaccinated against, and they're not, and their nutrition's addressed. That then, when they are exposed to malaria, which is inevitable in many places, that they then don't at least die from it, but they do grow some immunity. So I just wondered if you know of any historical strategies around that. Of course, those addressing poverty and nutrition are pretty difficult issues to address, but I just wondered if Gates or any of those other foundations are kind of looking at things more holistically, for instance. So that kind of ties the two questions together, I guess.
Sure. Well, let's see. I think that it's safe to say that the Gates Foundation embarked upon what was called in 2007 Malaria Eradication. They've now kind of backed off, and we're now using the term malaria elimination. And there are some nuances which are not insignificant, but the idea is largely the same. Embarked upon this with an enthusiasm that was not tempered by knowledge of the past campaigns. And so when the Gates Foundation made the announcement in 2007 to an audience of malariologists, apparently you could hear their jaws hit the floor. And people could not believe that somebody was talking about malaria eradication, because this had been tried, and some of the best minds and best medical researchers had committed their lives to this. And I have, great respect for the people who embarked on those campaigns, and the literatures that they produced are phenomenal and relevant even today. So that's a problem. There was an enthusiasm for malaria control, and this whole project started rolling forward without much thought about, well, was there an end game? Sure, it was clear if you use residual insecticides, if you use chemical therapies, if you use insecticide-treated bed nets, you can reduce the levels of transmission. That's been known. That's been known for a long time. It's not that hard. You just can't get to zero. And when you can't get to zero, donors lose enthusiasm. Oh, well, I think I might try this other project instead. That looks like it might be a more doable project, or maybe at that point the public health problem's larger than malaria is because you've been controlling malaria. But as soon as you turn your back on it, it springs back and it affects different age cohorts. And so that's a problem. So it's certainly the case that elsewhere around the world, we have seen that when people's incomes rise, that it's possible to dramatically reduce malarial infections. Why? Because when people's incomes rise, they get better housing. They can put screens on their windows. They can protect themselves. If you have electricity, you can set up a fan, and you can have the fan going over you while you sleep at night. Okay? Much more effective than a net. I mean, malaria used to be the largest public health problem in the United States of America in the 19th century. And we only got rid of malaria in the 1940s in this country. And we used to have malaria epidemics in Sebago in the 19th century. So it's not something that's terribly far removed from our experience even up here in Maine. Now, it is the case that other interventions, certainly reducing other disease processes, diarrheal diseases in particular, are going to have a big impact. However, malaria, even by itself, in the current situation, probably is perhaps the largest single disease burden, so that when interventionists have gone into villages and kind of eliminated malaria locally, they've been able to reduce childhood mortality by about 40% of all-cause mortality. But definitely they're interacting. But it's very confusing, and it's very difficult to sort out because the levels of transmission are so high. It's often said that every child who dies is parasitized with malaria, but every child who survives is parasitized with malaria. So it's very difficult to sort out the cause of death, particularly when you have multiple disease processes going on at the same time.
I was just wondering, countries like India, Philippines, Malaysia, similar type climate, poverty, and do they have the same problem? And if you don't hear it as large as, is this just localized to Africa, and why it just Africa, and are these other countries able to combat it by some other methods or something?
Yeah, great question. Well, to generalize, it's fair to say that there are perhaps 70 species of Anopheles mosquitoes that transmit malaria, but there's a big range in their competence. So some are really bad at it. They may occasionally transmit malaria, but they're not very good at it. They may get sick. Mosquitoes get sick from parasites too and die, or they don't live as long, they're not capable of transmitting malaria, or they have different biting patterns. So the African vectors Anopheles gambiae and Anopheles funestus and Anopheles arabiensis, are just the worst vectors. They're highly efficient. Many vectors, many mosquitoes, really don't care where they get their blood meal. Now, it's just the female's going to take blood. The female needs the blood in order to have her eggs develop. But most mosquitoes, or very many mosquitoes around the world, don't care at all where they get their blood meal. They're happy to get it from a bird, they get it from a dog, get it from a cow. They don't care where they get it. Human being, it's fine. But the African mosquitoes are highly specialized, and they have a very strong preference for human blood. So it's called the Anthropophily Index, how much you like to bite people. And they really like to bite people. So the Anthropophily Index is up around 100%. So that's another problem. They've got really efficient vectors. They've got strong preference for human blood. And then about 97 to 99% of all people who live in West and West Central Africa have a genetic mutation, a hemoglobin mutation called Duffy antigen negativity. And Duffy antigen negativity is a hemoglobin mutation that makes it impossible for people to get Vivax malaria. And Vivax malaria is the most common form of malaria in the world. So there's no downside. You can carry Duffy antigen negativity. You have no health problem. There's nothing, causes you no problem whatsoever in your life. It just makes you completely refractory to Vivax infections. But the ecological result of that is that it closes Vivax out of the malaria parasite mosaic. And this is why falciparum has such a large role. So that when you get an infection in Africa, it's 9.5 times out of 10 going to be a falciparum infection. And those are the ones that are really dangerous. Vivax will make you sick. It'll have a dormant liver phase. It'll go into your liver, and you can get sick a year later. It's really hard to clear compared to Vivax. But the death rates from Vivax are very low. It produces anemia. It's debilitating, but it's not going to kill you. Falciparum is going to kill you. And untreated, you'll have death rates on the order of 25 to 50%, absent medical intervention for non-immunes. So it's very dangerous. So that's why the disease environment in Africa is more severe than in India or Malaysia or Pakistan. And in those areas that participated fully in the Global Malaria Eradication campaign, didn't just have pilot projects, but went for national eradication because it was deemed feasible. They were able to reduce the level of infections by an order of magnitude. Okay? I mean, even beyond that, but when it bounced back, it came up at one order of magnitude below previous levels. By most standards, this would be accounted a major public health success. But the rhetoric of the Global Malaria Eradication campaign had pushed for elimination of the parasites, the end of malaria. And so in a public relations sense, it was accounted a failure because it was not able to get to zero. If we had other interventions and we said, wow, we're going to be able to reduce the level of dengue fever by 90%, or we're going to reduce mortality from diarrheal diseases by 90%, people would think, wow, what a fabulous intervention. This is great. But with malaria, it had a very, very different spin, and the World Health Organization took a beating politically because it was unable to achieve its goal. And in fact, it was very difficult to get the smallpox eradication campaign going, and D.H. Henderson of the Johns Hopkins School of Public Health and Hygiene had to make end runs around the administrators at the World Health Organization in order to get that program off the ground, and ran it on a shoestring.
I was just wondering, it's a great talk, thank you. whether malaria is a sort of horrific exception, or what rule or what that we've kind of learned here might be applied to things like dengue or giardia, river blindness, yellow fever, many of the things. I mean, are we looking at the same sorts of problems there?
I don't think so, because with dengue or with yellow fever, hemorrhagic fevers that are mosquito-borne, they're viral. So that we've got a vaccine against yellow fever. Now, because yellow fever is no longer afflicting the Americas, interest in producing the yellow fever vaccine is low. Yellow fever deaths are rising in West Africa. And yellow fever is an urban disease, and it's spread by an urban mosquito that breeds in containers. So it's a really different disease from a rural disease. But I think that there are good prospects for a dengue vaccine. So I think that for yellow fever and dengue, it's a different situation. The history of these parasites that cause malaria is just really an ancient one. And they're hundreds of millions of years old, and they have afflicted simian populations, and they afflicted proto-hominid, and they now affect hominid populations. I think that because there are wild reservoirs and some zoonotic transfers between wild animal populations and human populations, the prospects for full eradication are poor. However, I think that in tropical Africa, as elsewhere in the world, as incomes rise, we will see a reduction in malaria transmission. And then the other kind of good news, bad news part of this is that the Anopheles mosquitoes that transmit malaria need to breed in clean water. So that as Africa urbanizes, rates of malaria fall, because rates of transmission in urban areas are much lower than in rural areas because the water is filthy. Okay? There are lots of other public health problems that come with it, and there is a septic fringe that surrounds most of the core area, urban areas in Africa. So it's not something that's an unmitigated good by any stretch of the imagination. But just from a malariological point of view, the processes of urbanization are going to reduce transmission.
Yeah, I have read about counterfeit drugs being responsible for the lack of medical efficacy or treatment efficacy in Africa in the case of malaria. I even read about international criminal gangs dealing with counterfeit drugs that are supposed to go to malaria victims. What do you make of that?
Well, I think as a species, we're pretty unethical.
Yes.
And that's a problem. There are definitely a lot of counterfeit drugs, and there's money to be made from it. Talking to people who work on this problem, one gets some pretty distressing perspectives. For example, the packaging of counterfeit drugs is identical to the packaging of the real drugs. This suggests that the drug factories have two shifts, and they make some real drugs and they make some counterfeit drugs. So it's a complex problem. And of course, counterfeit drugs or drugs with low efficacy are one of the forces that speed up the emergence of resistance in the drug, because if you're taking a suboptimal dose and the parasites are exposed to a suboptimal dose, you can select for resistance more easily. So the counterfeit drug, quite apart from the moral issues, has an epidemiological significance too. It's difficult to get a full handle on it.
Well, thank you so much, and this concludes our session.